Good evening, respected senior members of the profession, dear members of learning general surgery. I sincerely express my thanks to Dr. Prathapan for allowing me to do the third topic, this the surgical anatomy of liver. So this is a very important topic as far as HPB surgeon and GI surgeons are concerned. It will be basic to advanced. So there are many general surgery postgraduates attending this meeting. They may also get benefited. So no discussion on liver anatomy without this picture. This is a very famous picture based on Greek mythology. And this eagle represented the first person who identified the regenerating capacity of liver. This is the story of Prometheus. He was punished by God for stealing the torch from God and giving fire to mankind. So this eagle is allowed to eat the liver of Prometheus, and he will eat the part of liver, and the very next day it regenerated and Prometheus did not die of this. So this was the basis of liver surgery, and apart from eagle, no human dared to remove a part of liver for so long with the fear of bleeding and mortality. So basic principles of liver surgery include a segment-oriented surgery, maintenance of a functioning residual liver volume with parenchymal preservation as far as possible, with a good inflow, good outflow, and good biliary drainage. So a good knowledge of anatomy is crucial for performing liver surgery. So liver is the largest gland in the body, representing around 2 to 3% of adult human body weight. Historically, liver resection was associated with a very high morbidity and mortality. Even till 1980s, the mortality of liver resection was to the tune of 10%. But there was tremendous improvement in the perioperative outcome of liver surgery because of excellent preoperative imaging, including the volumetry analysis, better knowledge of the liver anatomy and the function. There is improvement in operative technique and newer electrosurgical devices, and there is a very much improvement in the anesthesia and critical care in the post-op setting. So approach to liver is different when you do liver surgery for a liver tumor or a metastasis, or do a surgery for a hilar cholangiocarcinoma, and for patients in whom you do a living donor liver transplant surgery, that is the donor hepatectomy. For hilar cholangiocarcinoma, the current trend is to preserve parenchyma as far as possible, because we are removing the gland liver because of getting a negative margin on the duct. And as far as living donor liver transplantation is concerned, both the removed segment as well as the segment which is retained is very important, and you cannot compromise on the inflow, outflow, and the remnant liver. So history of liver surgery goes back to the myth of Prometheus, and the liver of a sacrificed animal was used when they look at the surface, and they used to predict the future, especially by the Assyrian and Babylonian culture. And Hippocrates was the first person to recommend incision and drainage of a liver abscess. And Galen described the central role for liver in the absorption and digestion. It was Francis Glisson who did an extensive workup on the vascular anatomy of liver. And Hugo Rex and James Cantlie identified the line of division of liver into right and left liver in 1897. So this was the Francis Glisson's portal circulation, which is published in the book. So the Langen book, who did the first polycystectomy, was the first person to do a successful hepatic resection. But interestingly, the surgery was done for a benign liver tissue rather than for a tumor. So in 1908, John Hogarth Prinkle described the method of inflow control, that is called the Prinkle manure or Prinkle pitch, which actually improved the results of surgery, especially in trauma surgery and in war surgeries. It was Ton That Tung, the famous Vietnamese surgeon, who did extensive work on liver segmentation, and he published his data even before Cuisinart published his data. In 1952, Lothar Jacob actually identified the method of clamping the pedicle to a lobe, and he did the right hepatectomy after vascular control of the right liver. In 1956, Coronary published his detailed study on anatomy of liver, including the segmental anatomy of liver, and Thomas Tarsal did the first deceased donor transplantation in 1967, and there was tremendous improvement in the field of liver surgery, and hepatobiliary surgery became a separate specialty in most of the countries. So development, we already discussed. The liver develops from an embryologic foregut as a diverticulum known as the hepatic diverticulum. The proximal portion develops into the liver, and distal portion develops into gallbladder and cystic duct. The endodermal cells differentiate into the hepatic cores as well as the epithelial lining of bile ducts. So this is fetal circulation. Some of the remnants of fetal circulation remains in the adult as some of the named ligaments. So that is why I put a picture. The ductus venosus becomes the arrangeous ligament, and the left umbilical vein becomes the ligament of teres. So to begin with, the embryo will have two umbilical veins, the right and left, but the right disappears early. The left persists till the fetal circulation is there, and after that it will get obliterated and becomes the round ligament. And the ductus venosus, which takes blood from the liver in the left portal vein to the IVC, become the arrangeous ligament. So coming to the anatomy of liver, liver is situated in the upper abdomen. Actually, it is a thoracic organ situated in the abdomen. It is overlying the liver bed, which is made of the cupule of diaphragm, on either right kidney, right adrenal gland, part of stomach, etc. And one important question in the transplant surgery: what keeps the liver in position after your implantation is done? Is it the ligaments, or is it the hepatic veins, or is it the negative intrathoracic pressure? I didn't get a correct answer even after checking it. I think some of you can answer it. So coming to the anatomy of liver, by definition, a lobe of a liver or any organ is a part of an organ that may be demarcated from the rest of the organ by a fissure, sulcus, or a connective tissue. So it comes from the Greek terminology called lobos. So hence liver has four lobes morphologically, because these are the four lobes which is described by either sulci or fissures. So liver has a larger right lobe and a smaller left lobe, has a quadrate lobe and a caudate lobe. So we will hear more about lobes later. There is a lobe called the Riedel's lobe, described by Riedel in 1888. It is seen in around 3.3% to 31%, depending upon the criteria used for diagnosis, and it has a female predominance. It is not a true lobe, but a simple anatomical variation. There is a tongue-like projection from the right posterior part of the liver, and it is separated from the rest of liver by a transverse narrowing of the parenchyma. Sometimes that narrowing part may be deep and may be only a connective tissue, and this type of lobe may go into torsion and present as an acute abdomen. The Riedel's hypothesis of developing Riedel lobe is elongation of the lobe from a traction exerted by inflammation in the adjacent organs. So Riedel's lobe is not a congenital abnormality, it is an acquired abnormality. So there are many ligaments described in liver. They are all the peritoneal attachment. In fact, they represent the remnants of the ventral mesogastrium in which the liver develops. So we have the peritoneal attachment in the form of falciform ligament. The ligament teres is seen in the lower part of falciform ligament. You have coronary and triangular ligament, and you have lesser omentum. So the falciform ligament attaches the anterior surface of liver, and it extends from the upper part up to the umbilicus. And it is actually represents the vestige of ventral mesogastrium. And the lower border has the ligamentum teres. It represents an obliterated left umbilical vein, which runs on the free edge. Actually, the ligamentum teres is not obliterated. Its lumen is actually closed at one end. We can actually recannulate the ligamentum teres, and we can use it for access to the left portal vein. And these ligamentum teres get dilated in patients with portal hypertension, forming an important portosystemic collateral. The surgical significance of ligamentum teres, it is actually this particular ligament comes into a way of liver surgeon. So you have to remove it, you have to excise it or you have to keep it somewhere. So sometimes small parabolical vein from the portal system to the umbilicus runs along with the ligamentum teres, and these get dilated, and it actually runs between segment 3 and segment 4. And the area where the ligamentum teres attaches to the left portal vein represents the entry point of segment 3 bile duct to the left hepatic duct. So you can actually access the segment 3 duct in that area, and this approach is known as the ligamentum teres approach. This was an important technique for biliary palliation in hilar cholangiocarcinoma and carcinoma gallbladder, but now with the advent of interventional radiology and stenting, we don't do this surgery no more. So the falciform ligament has 2 layers which spreads out in the base to form the anterior layer of coronary ligament on either side. So it's a relatively avascular structure, and the posterior most portion of the ligament actually has the entry of the hepatic veins into the IVC. So the base actually forms a triangle. The base of the triangle is formed by the left and middle hepatic veins. In around 15% of patients, we will see a falciform artery, because this falciform artery is a branch of middle or left hepatic artery, and it connects with the epigastric arteries. So if you do some chemoembolization and all, there may be necrosis around the umbilicus in these patients. So you have to be very careful in doing this sort of treatment in patients with a persisting or a patent falciform artery. The coronary and triangular ligament are actually again the peritoneal attachment, and the right and left triangular ligament actually bounds the bare area of liver, where you see the liver is in direct contact with the diaphragm, not much of any peritoneal layers, but there are some small connective tissue between the diaphragmatic area and the liver. So the triangular ligament and coronary ligament are mainly seen on the right side, and small portion is seen on the left side, and it continues with the lesser momentum towards the caudate lobe. So the entry of IVC and entry of hepatic vein are actually seen in the bare area of liver. So for mobilization of liver, for doing hepatectomy, you have to actually excise these ligaments. You have to do excision of these ligaments, because they are all vascular structures. So next comes the Glisson's capsule. Even though Glisson's capsule is described by Johannes Vallius, because the Waloean sheath by Coinard comes from that Johannes Vallius, and he described the Francis Glisson described the Glisson's capsule. It wraps the hepatic artery, portal vein, and bile duct in the liver, and it forms bundles at the hepatic hilum and in the liver as a Glissonian pedicle tree. So you can see it as a tree starting from base at the hepatoduodenal ligament going into the liver. So the Glisson's capsule does not connect to the proper membrane of liver. So there is a separate membrane which actually covers the liver. So that is called the Lennox capsule. So the Glisson's capsule can be separated from liver parenchyma because of this second layer. So that's called the Lennox capsule, described by Lennox in 1802. It's a membrane covering the liver distinct from the serosa. So it has no continuity with the Glisson pedicle. And this Lennox capsule is a dense fibrous layer beneath the serosa on the surface of bare area on the Glissonian pedicle. It is seen everywhere, and it actually dissociates from Glisson's pedicle and extends to the peripheral Glissonian. So this is the Lennox capsule which I was describing. The red line actually represents the Lennox capsules. You can see it extends into the liver, and it actually separates the Glisson's capsule from the parenchyma. So there are some areas in which there is weakening in this sheath, and that area is used by liver surgeons for doing what is called the anterior approach, or what you call the hanging liver maneuver described by Belgetti, where you open the space in the lower part, especially in the above the caudate lobe, and identify a retrohepatic space over the IVC, and that tunnel is used for hanging the liver. That's called the hanging liver maneuver by Belgetti. So The next important thing is the arrangeous ligament. Actually, it represents the vestige of ductus venosus of Arranchi. It connects to the left portal vein area to the junction of left hepatic vein and middle hepatic vein into the IVC. So the important aspect of arrangeous ligament is that it is actually a surface marking of left hepatic vein, middle hepatic vein, and it can be used for isolating the left hepatic vein or controlling the left hepatic vein. And you have to cut this ligament at the medial aspect near the portal vein entry to get extra length for the left portal vein. And the same ligament has to be excised when you have to isolate the umbilical plate when you perform what is called the Cassai's operation done for biliary arteries. So the next important structure there is the hilar plate. I actually discussed the hilar plate in the last class. It's a half cylinder which is open towards the base. Actually, the base of hilar plate is formed by the lower part of caudate, quadrate lobe, that is the segment 4. So it extends to the right into the cystic plate or near the gallbladder, to the left at the umbilical fissure. Actually, the anterior Glisson sheath is the right boundary and the umbilical fissure is the left boundary. So it is actually a connective tissue which invests the structures at the hilum, like the hepatic artery, portal vein, and the bile ducts. And there are lymphatics, nerves, etc. along with that. So this plate is actually a tube, and which can be converted to a plate only after surgical dissection. So there is a technique called lowering of hilar plate. It is described by Hebb and Coronary way back in 1956. It is actually making an incision on the upper margin at the base of caudate lobe and elevating the caudate lobe, quadrate lobe upwards and depressing the confluence of the bile duct. That this area you can actually dissect the bile duct easily. And toward this area, the portal vein is actually loosely attached, and you can have the hepatic artery and bile duct closely attached. So the release of portal vein is a little bit easier. But when it reaches the umbilical plate, the hepatic artery, portal vein, and the bile duct, everything will be very close, and it is very difficult to separate at least the bile duct and hepatic artery. So this actually forms the basis of the Glissonian pedicle approach for the liver surgery. Rather than separating individual components, we will ligate this en masse. So this is the hilar plate after removal of the important structures. So the right picture is before removal and the left picture shows after removal, and you can see it's as a tube. And you can see the sheath covering the anterior section pedicle and posterior section pedicle. And the cystic plate is located at the gallbladder, and it represents the posterior edge area of the Cantlie, which I will come to later. In more than 83%, posterior edge of the cystic plate is located on the right side of right portal vein branch. So the umbilical plate is located along the inferior edge of ventral surface of umbilical fissure. It contains the ducts and blood vessels to segment 2, 3, and 4. And it continues with the round ligament inferiorly. And at the level of umbilical plate, you can distinguish 3 concentric planes. These are the 3 concentric planes. The green circle indicates the peritoneal. The red circle actually the layer on the hepatic artery, and the blue is on the portal vein. So coming to the arteries which supplies the liver, you can have the right, middle, and left artery. This is one recent image which I am showing. A patient who has a right hepatic artery completely arising from superior mesenteric, and a middle and left arising from cilia. So you have 3 arteries: the right, left, and a middle artery. So the middle one usually supplies the segment 4. So there are many variations which we discussed in the last class. It's a Michael's classification of up to 10 different variations are described, of which the right, accessory right and accessory left are very important. And most of the accessory right arteries supplies the right posterior section. So the portal vein variations are seen at the hilum. These are the classifications described. One type A is the normal type where the right and left portal vein divides. So it's called Cheng's type 1. And type B, there are triple confluence. And type C, you can see the right anterior sector and left joins together and the right posterior is separate. And the type D and E, these are all difficult anatomies where you cannot resect the liver without doing a reconstruction of the portal vein. So there is a congenital abnormality described. It's called Abernethy malformation. It's a congenital extrahepatic portosystemic shunt. The portal vein may be absent or rudimentary. It is classified into type 1 and 2. Type 1 again classified into A and B. Type 1, there is no portal vein at all. The superior mesenteric vein, splenic vein joins the IVC or other veins like renal vein or iliac vein in an end to side fashion. Whereas in Abernethy type 2, there is a rudimentary portal vein with a shunt. So coming to the intrahepatic bile duct, at the hilum, there are many variations described. This is type A, B, C, D. We discussed in the last class. Of is the type A is the 57%. There is no normal biliary anatomy. So inconsistency is the consistent feature in the biliary anatomy. That is what we talked in the last class. So we have another classification for the aberrant right posterior sectoral duct. It is called Isatsubu's classification based upon the relationship between right posterior sectoral duct and the cystic duct junction. It is type 1 where cystic duct joins the posterior sectoral duct. Type 2, both cystic duct and posterior sectoral joins as a separate, almost at the same point into the common bile duct. Type 3, you have posterior sectoral duct joining the common hepatic duct. Type 4, you have the posterior sectoral duct joining the CPD more distally, below the level of cystic duct entry. And type 5, you have the posterior sectoral duct actually join the cystic duct. This is very important when you do laparoscopic surgery or when you do surgery for carcinoma, gallbladder or hilar cholangiocarcinoma. So in the intrahepatic biliary anatomy, you have an important thing known as the George's crook, which I mentioned in the last class. There is a north turning type and a south turning type. If there is a north turning, that is the common type. There is an increased risk of injury when you do anterior sectionectomy to the posterior bile duct. So the hilar cholangiocarcinoma, again we have the supraportal type, infraportal type and mixed type of right posterior sectoral duct described. So if you do surgery for hilar cholangiocarcinoma, the supraportal type actually has some difficulty. There will be a higher margin positivity after resection. There is a difficult biliary anastomosis because this duct is seen deep to the portal vein and it is in depth, and there will be a higher bile leak after surgery because of this difficult anastomosis. So this is the intrahepatic biliary anatomy variations. The majority of variations are either in the segment 4, segment 5 or segment 6. So the biliary anatomy of segment 4 again divided into type 1 type of anatomy and a type 2 type of anatomy. The type 1 biliary anatomy is the before duct joins the left hepatic duct in the hilar confluence area. Whereas in type 2, the before duct joins the left duct away from the confluence area, which is the common type. The important thing is that in type 1, the early involvement of this duct is the rule. So in patients with the type 1 before anatomy, if you are doing surgery for hilar cholangiocarcinoma, you have to resect the quadrate lobe. So the next comes the concept of Glissonian sheath. Actually, I mentioned this. This is a fibrocollagenous sheath which envelops the structures which enters into the liver, and it forms something like a tree, which is the picture I have actually shown. The important thing about the Glissonian sheath approach is in liver surgery is that almost all the variations in arteries, veins, and the bile duct occurs inside the Glissonian sheath. So if you go by the Glissonian pedicle approach, the chances of injuring the aberrant ducts are less. So this is the Glissonian pedicle tree which I was mentioning. This is from Takashaki's article on Glissonian pedicle approach. These are the Glissonian pedicle isolation for right liver, where there are weak points described in the literature. You can access this pedicle at these weak points. So this is very important step when you plan laparoscopic liver surgeries, because in laparoscopy, dissection at the hilum is a difficult process. So if you identify the Glissonian pedicle to individual segment, you can do laparoscopic surgery easily. During surgery, you can use the vascular staplers to ligate the Glissonian pedicle. So this is the left liver Glissonian pedicle described. So then I will come to the venous anatomy of liver. Starts from the retrohepatic IVC. It's actually embedded in the liver tissue, either partly or completely. The IVC has no valves except some vestigial valve situated around the atrial opening. And the right adrenal vein actually enters the posterior aspect of inferior vena cava. This is very important for liver surgery. When you mobilize the liver, this is the vein which produces bleeding, because it's a very short vein which is seen at the junction of the suprarenal IVC and the retrohepatic IVC. So there are other veins which enters the IVC. These are the right inferior phrenic vein joints above the entry of right hepatic vein, and there is the left inferior phrenic has got a posterior branch and anterior branch. The posterior branch actually joins the left renal vein, whereas the anterior branch joins the junction of IVC or IVC with the left hepatic vein or the left hepatic vein itself. So there is a very important structure described. Actually, the description of hepatocaval ligament by Makuchi is a very important thing in anatomy of liver, because before this, everybody thought that to get an access or to control the suprahepatic IVC, we have to open the pericardium. But once we identified the anatomy of Makuchi's ligament and the technique of excising this hepatocaval ligament, we could mobilize the IVC and the hepatic veins easily. So this is actually what is called the liver to liver, parenchyma to parenchyma ligament seen in the around the IVC area. So which has to be cut to expose the right hepatic vein, or if you have to mobilize the IVC, you have to do it. So excision is a very important step in liver mobilization, doing surgery for donor hepatectomy, especially the right donor hepatectomy, for repairing the IVC in patients with we call the Biliary syndrome. So this is a very important structure. And it is also important to mobilize this ligament when you plan to do excision of the dorsal part of caudate lobe. So this is the Makuchi's ligament which I was mentioning. You can see the right suprarenal gland here, right suprarenal vein here, and you can see the hepatocaval ligament. Sometimes this hepatocaval ligament, at least in 50%, there will be parenchymatous tissue, and which makes it difficult during surgery. You have to apply vascular staplers to cut the Makuchi's ligament. So next comes the hepatic veins. So you see a picture of IVC with the major veins which drains into the IVC, and there is a space on the anterior surface of IVC. That space is used by some of the liver surgeons to do what is called the hanging liver maneuver. That is a very common maneuver done by the transplant surgeons. So the veins of liver can be divided into superior, middle, and inferior group. The superior group comprises of right hepatic vein, middle hepatic vein, and the left hepatic vein. The middle group, the right middle right hepatic vein, or the superior hepatic vein of the caudate lobe. And the inferior group is the right inferior hepatic vein and the caudate veins. So these are the hepatic veins. The right left picture shows the important hepatic veins, the right hepatic vein, middle, and you can see the umbilical fissure. I will come to it a little while later. Then we can see the inferior hepatic vein, which is in the middle picture on the lower segment. So the inferior hepatic vein. So the right hepatic vein actually responsible for around 35 to 40% of entire hepatic venous drainage area. So in most of the persons, the right hepatic vein drains majority of liver. And it has a length of around 12 centimeter, and it is actually seen in the right fissure between anterior and posterior. I will come to the segmental anatomy soon. It drains part of segment 5, segment 8, and whole of segment 6 and 7. If there are no other veins, right inferior veins, and it receives around dozen tributaries on either sides. There are main tributaries are, one is called the right superficial vein or the RSV, and the other is the dorsal vein of segment 8. So it's called a V8 vein, V8D vein. So it joins the right margin of IVC below the level of entry of middle hepatic vein and left hepatic vein trunk. And there are no tributaries in the last 1 centimeter of vein in around 60%. And you see the picture in the upper part actually shows the right inferior phrenic vein by arrows. That shows the entry of right hepatic vein into the IVC. So if you trace the right inferior phrenic vein, you can actually identify the entry point of right hepatic vein into the IVC. So the lower picture actually shows the percentage of liver right lobe drained by the right hepatic vein. So the middle hepatic vein is seen in the main portal fissure, responsible for around 33% of hepatic venous drainage, and it mainly drains segment 4, 5. There will be variation, and it forms by segment 5 vein on right side and segment 4 vein from the left, and it receives a main tributary from segment 8. Actually, this segment 8 vein is a very important vein because it may be sometimes mistaken for middle hepatic vein during liver surgery. So in more than 90% of persons, especially in East, the left hepatic vein and middle hepatic vein forms a common trunk before it enters into the IVC. So the main tributaries of middle hepatic vein are superior vein of segment 4, inferior vein of segment 4, ventral vein of segment 8, intermediate vein of segment 8, and veins of segment 5. So the lower picture actually indicates the percentage of liver drained by the middle hepatic vein. So there is something called a dominant middle hepatic vein, in which a long segment 6 vein drains into the middle hepatic vein. And after doing surgery, if you excise or if you ligate the middle hepatic vein, the segment 6 will go in for congestion. The next is the left hepatic vein. Actually, left hepatic vein drains only 20 to 22% of entire hepatic liver parenchyma. The main tributaries are the left superficial vein and the umbilical fissure vein. And the left superficial vein drains segment 2 and umbilical fissure vein drains segment 3 and 4. And majority of segment 2 and 3 drained by the main shaft. So this is the umbilical fissure vein which I was mentioning. This is a very important vein seen between the segment 3 and 4. Usually drains to left hepatic vein, may drain to middle hepatic vein or a trunk of left and middle hepatic vein. And in patients who are planned for segment 2 resection with the left hepatic vein ligation or excision, this may actually results in no congestion of the segment 3. Because if you want to excise segment 2 with left hepatic vein, the umbilical fissure vein, which is draining to the middle hepatic vein, is of help. The accessory hepatic veins I was mentioning, one is the middle right hepatic vein, which exclusively drains segment 7. So middle hepatic vein, which is seen in around 8%, will not drain segment 6. Whereas the inferior right hepatic vein, which will drain mainly the segment 6 and occasionally it will drain the segment 7, it is seen in around 12 to 16%. So a vein of more than 3 millimeter is considered as significant. And if you see the 3D reconstruction of the venous anatomy, if there is a vein less than 3 millimeter, which is not indicated, whereas if there is a vein which is more than 3 millimeter, it is indicated as the inferior or the middle right hepatic vein. And any vein which is of more than 5 millimeter needs to be reimplanted. So these are the inferior right hepatic veins. The classification: type 1, there is no inferior hepatic veins. Type 2, an inferior hepatic vein is present, but the size is smaller than the right hepatic vein. Whereas type 3, there is inferior hepatic vein present, but the size is equal to that of right hepatic vein. So what is the significance of this drainage pattern? Because there is a dominance of middle and the right hepatic vein. It depends on individual variation. So if there is congestion after surgery, the segment of liver which is congested, which will atrophy, which will not regenerate, sometimes it may undergo necrosis. So you have to prevent congestion in the remnant liver as well as in the liver which is being implanted in transplant surgery. So when there is a middle hepatic vein dominance, the chances of congestion is small. So previously at the beginning, people used to take the right lobe with the middle hepatic vein completely. So the donor has a problem of congestion or of the segment 4 and all. So they moved on to the modified right lobe graft, where they won't take the main middle hepatic vein. Instead, they take the segment B, segment 5, 8 veins and reconstruct and finally implant as the modified middle hepatic vein. So that is the importance. So if you have an inferior hepatic vein, you have to identify the size, number, and distance of inferior right hepatic vein from RHV. Because if there is more distance, the reconstruction, more than 4 centimeter between these two veins, the reconstruction is difficult. You may have to do a separate venoplasty technique. So if you have a large inferior right hepatic vein, and if you are planning a right lobe resection with the right hepatic vein, the segment 6 can be spared. If there is no involvement of segment 6, but if you want to take the right hepatic vein, patient has a dominant inferior right hepatic vein, you can actually preserve the segment 6. So in patients undergoing surgery, the segments, the inferior right hepatic vein is very important. So coming to the important topic, the segmental anatomy of liver. These are the stalwarts, the upper picture, Hugo Rex and James Cantlie, then Tontat-Tung, then Coynard, Starsell, Henry Bismuth, Russell Strong. So this is the Rex-Cantlie line. You can see left side, the Rex-Cantlie line. It's a line representing the main portal fissura. The right side picture shows the CT drawing of the Rex-Cantlie line. So what is the hypothesis of intrahepatic liver segmentation? The portal vein and hepatic vein branches interdigitate with each other 3-dimensionally. And the main veins are seen in the grooves known as the fissures. They are known as the portal fissures. So all the portal fissures contains hepatic vein, and all the hepatic fissures contain portal veins. So the Rex-Cantlie line is the main division plane between the functional right and left liver. We can't call it as lobe, right lobe or left lobe. We call it as right liver and left liver. And this is known as fissura in French literature. So the main portal fissura runs infra-posteriorly through the middle of gallbladder bed, and it passes slightly to the left at the porta hepatis and pass in the middle of the region where portal structures bifurcate, and then passes across the caudate process. That is the posterior extent. Anterior extent, everybody knows, from the middle of the GB fossa to the left of inferior vena cava. The Rex-Cantlie described this line back in 1897, but it was popularized by the studies of Tontat-Tung and Coynard. It actually makes an angle of 75 degrees towards the left, and middle hepatic vein is seen either partly or wholly inside the plane depending upon its formation. So you can actually learn the liver anatomy by seeing the right hand fist. The thumb represents the actually the caudate lobe, and the other fingers represent. So you have 3 lines, that is the representing the actually the hepatic veins, and there is a transverse line that is corresponding to the portal vein. So these are the major fissures which divides the liver: the anterior fissure, the what is called the right fissure. Then you have the main fissure, that's called the Cantlie's line. You have the left fissure. Actually, there is a difference in terminology which is used now and which is described by Coynard. Because in Coynard's literature, the left fissure actually contains the left hepatic vein, and he divided the left liver differently, like a left lateral segment or left posterior sector and a left medial sector. Whereas the current terminology, they changed this. So the right fissure actually contains the right hepatic vein. It is actually a vertical plane, the anterior border of which is parallel to the right edge of the liver, and the plane is variable between the GP fossa as the right and right edge. It can actually move either towards the main portal fissure or away from. Depending upon that, you can have the size of segment 5 varying. When the right fissure moves towards the Cantlie's line, the segment 5 will be smaller one. The left fissure actually runs from the left side of IVC to the umbilical fissure and to a point between dorsal 1/3 and ventral 2/3 of the left margin of liver. So the ventral 2/3 actually represents segment 3 and 4, and the dorsal represents the segment 2. When we learn the Coynard's segmental anatomy, it was told that the left posterior sector is the only sector containing a single segment. Now that terminology is changed. So the hepatic left fissure is actually between segment 2 and 3 by Coynard, and it is actually containing the left hepatic vein. Whereas the current terminology of left lateral segment is segment 2 and 3, and where the division is by the umbilical fissure. Even though the umbilical fissure is used as the division point, it is not a portal fissura because it contains the portal pedicle. So when it contains a portal pedicle, it is not a portal fissura, it is a hepatic fissura. But there is a small vein beneath that portal fissure that is called the umbilical fissure vein. So the terminology of liver anatomy is differently given by different persons. The left side is the Takasaki segmentation, which is popularly in dividing the liver into right, middle, and left, and the caudate lobe separately. Then the Goldsmith and Woodburn divided liver in posterior sector, anterior sector, the caudal sector, median sector, lateral sector, like that. We use different terminology. I will come to it later. So the liver is divided into 8 segments, and it is by an by a clockwise direction when you look from above, and when you look from below, it is in the anti-clockwise direction. So the segment 1 is posterior, and the segment 8 is the last segment described. So it's a numbering 1 to 8 in a clockwise direction. So this is the visceral surface of liver. You can see the segment 2 is lying in the lower part compared to the segment 3. But the position of segment 2 and 3 changes. Individual variations are described. So this is the cut section of liver, and you are looking from the lower aspect towards up. So when it is at the upper margin of the hepatic venous level, you can see the segment 2 on the left side, segment 4, 8, and 7. When it is at the lower margin at the level of the lower part of hepatic vein, you can see the segment 4, 8, and 7 coming into view. On the left side, you have segment 2 or 3, depending upon which area is. Then when it is at the portal vein bifurcation level, we can see the segment 3, segment 4B, segment 8, and segment 7. So when it is at the splenic vein, superior mesenteric vein junction, we can see all the inferior segments, 3, 4B, 5, and 8, 5 and 6. So the American system popularized by Williams, it is slightly different from the Coynard system, because in Coynard system, segment is the last portion. So one American segment is equal to 2 Coynard segment, and one American subsegment is equal to 2 Coynard segments. So we use Coynard terminology mostly. So since there was a confusion in Coynard's terminology, there was a consensus meeting in Brisbane headed by Strasberg, and they changed the terminology of liver into sectors. Instead of dividing a section, instead of sectors, they used the term sections. So they divided the liver into first order division, second order division, and third order division. And the second order division, you can see the left lateral part is actually containing the segment 2 and 3. Whereas in Coynard section, the left lateral part is actually the posterior section that contains only segment 2. So there is a concept of anterior fissure. This is an anterior fissure is a fissure which actually divides the anterior sexual duct into a dorsal and ventral part. This is popularized by George Joe and Japanese So there is an anterior trunk of portal vein, but we don't know what is the division between the segment 8 and segment 5 in individuals. So actually the anterior sector of the liver is divided vertically rather than horizontally, which we expect as segment 5 and 8. Vertically they are divided by a fissure that is called the anterior fissure, and that anterior fissure is crossed by a vein that is known as the anterior fissure vein. So this is the anterior fissure vein. You can see the vein actually crosses the anterior fissure, and it is classified as type 1, 2, 3 by the surgeons, depending upon whether there is a single vein, whether there are multiple veins, or whether the vein is absent. So this is the concept of anterior fissure vein. Because these umbilical fissure, anterior fissure vein, etc., are very important when you do parenchyma preserving surgeries, because when you preserve these veins, you can actually preserve some amount of parenchyma. When you do surgery in cirrhotics or other patients, the conservation is extremely important. This is the concept of cone unit. Actually, the Takasaki described this cone unit where they have the liver division into segments. Then each segment of liver is divided into 6 to 8 cone unit. So it is not like the segmentation described by the Coinard or other investigators. It's a different terminology where each segment is divided into cone unit. So the concept of subsegments, because some of these segments are of larger size. So for improving parenchymal preservation, they identified the subsegments. So the segment 8 is divided again into 8A, B, and C, or otherwise called segment 8D, B, and with a separate portal pedicle to these segments. Because if we consider the anatomy of segments, we think that there is only a single portal vein entering a segment. It is not correct. It may be a single portal vein to begin with, but it will form 3 pedicles to supply part of a segment. So based on this, they have divided the liver into individual sub-segments. So segment 4 is divided into segment 4A and segment 4B. So this is a very popularly used term, but the Japanese used it differently. Our segment 4A is Japanese segment 4B, and our segment 4B is Japanese segment 4A. But for practical purpose, we use segment 4A is above and segment 4B is below. So that is easy to remember. So the part of segment 4 which is close to the hilum is actually segment 4B. So doing parenchyma preserving surgery, the medial, what you call Taj Mahal surgery, etc., we resect this segment 4B, not segment 4A. The last part of my talk is on caudate lobe. Caudate lobe is a very important structure as far as liver surgery is concerned. So it's actually the target for radical surgery in cancers of liver, especially in patients with hilar cholangiocarcinoma. In living donor liver transplantation, nowadays people are using caudate lobe to increase the graft volume. At least 9% increase can get by using caudate lobe. And in patients with the involvement of caudate lobe like tumors, the radical surgery is very difficult because isolated caudate lobe excision without removal of either lobe of liver is very difficult, because the caudate lobe is having a very critical location. So caudate lobe is described first by Adrian Van den Spiegel. So actually this Spiegel in the word meaning is mirror. The caudate lobe is actually represented the mirror of the other liver lobe, because it developed later than the other liver lobes. But it was Coinard who coined the term the dorsal sector, and the Glisson coined the term Spiegel lobe. So this is the location of caudate lobe, which is a very critical location. You can see the IVC posteriorly, the portal triad inferiorly, and the hepatic vein confluence superior. So it is very difficult to remove this part of liver. So there is increased chance of bleeding, increased chance of damage to the major venous structures. So caudate lobe is actually divided into 3. One is the spigal lobe or the caudate lobe proper, which is situated to the left of IVC, and there is a paracaval portion which is in anterior to the IVC, and there is a caudate process which is situated to the left of, actually to the right of IVC. So there is a notch in the spigal slope that actually represents the watershed between the left part and the right part. So the Caudate, the Poinard used the term segment 9 for the paracaval portion and Caudate process together. So there is a separate segment for Caudate lobe. The left is the segment 1 and the right, the paracaval portion and the Caudate process is termed as segment 9. So that is the division of caudate lobe which I was mentioning. Sometimes you may see a papillary process arising from the caudate lobe proper or the spigal lobe, and that may mimic a lymph node. So the paracaval portion is actually situated in front of the retrohepatic IVC, and it is closely attached to the right and middle hepatic vein. So this is the anatomy of caudate lobe. You can see the CT image showing the caudate lobe proper, paracaval portion and the right portion. The caudate process is actually attached to the segment 6 or segment 7, and you can see the caudate process. When you lift the liver hilar structures, you can see the caudate process. So there is a concept of 3 porta hepatis, which is popularized by Henry Bismuth. So the first porta is actually the hepatic hilar. The second porta is the confluence of major hepatic veins, and the third porta is the segment of retrohepatic IVC with a series of short hepatic veins. So this third porta is the important venous structure which drains the caudate lobe. So you can say the caudate lobe is surrounded by all 3 porta hepatis: the first porta, second porta, and the third porta. So the caudate lobe pedicle, the portal vein, usually the right portion, the portal vein comes from right portal vein or the confluence of right and left portal vein. The left portion usually is usually supplied by the left portal vein. The arterial supply and venous biliary drainage is again the right portion by the right posterior sacral pedicle. The left portion is to the left pedicle. So the venous drainage is the only hepatic segment directly draining to IVC. This is very important when you have veno-occlusive disease or in cirrhosis. There will be relative enlargement of caudate lobe because the venous drainage of caudate lobe is independent of other liver segments. So they are drained by a series of short hepatic veins directly into the IVC. And none of the veins are more than 3 millimeters. So the detection of caudate veins in the imaging is very difficult. But in some patients, there may be, especially when there is a large tumor or when there is a tumor arising from caudate lobe, there will be branches coming from right hepatic vein or middle hepatic vein from above. So that is a very difficult situation where you can't access these veins, and you may have to open the liver vertically or the split liver vertically and to identify the confluence of the major hepatic veins. So that will be the end of my talk. I think I could finish almost all important thing in the anatomy. So if there is any doubt, I will be able to.
But Prathapan, this is the best lecture I have heard on liver, I'll tell you, till date. It's a wonderful lecture and well researched and very, very clear. Thanks for that. And there's a second part to it, is right?
Yeah, maybe I am preparing that. If
yeah, you take your time. Yeah, anyone from the audience or any questions, please come up. Sriram, but wants to know.
No. After that I put that one a little earlier, but later I saw the diagram, everything it is detailed. But usually students postgraduates, they say only segment 8, at least MS postgraduates. Whether they should add on to segment 9 as a part of.
Sir, are you the author of the book?
Yeah, I am Dr. Sriram, but author of the.
Then you should be talking, giving lectures in. I was trying to locate you. I couldn't get your telephone number. I'm very glad if you can become a faculty in LGS, sir.
I will send my.
Yeah, to my messenger. Please send your contact details. It's wonderful seeing you here. So, what is that you're commenting on?
No. I was knowing about segment 9 before he has shown the segment 9. I questioned that. I just put the message segment 9 should be mentioned or not. After that, he had detailed everything. It's excellent talk. I know Prathapan from Calicut. I am from Mangalore. So they are nearby.
Anyway, nice seeing you, sir, because I've seen only your books. I have not seen you or heard you though. So it'd be nice if you can join the the excellent faculty in learning health. I've been trying to reach you actually.
Thank you, but I've been listening to most of the lectures quite well. Yeah, really? That is wonderful. So, a very nice talk from Pratap. It's excellent, very informative. Yeah, most of our postgraduates are joined today. I've been insisting them to join.
Pratap does very thorough job, and he's made for this actually.
Perfect. Thank you.
Anyone else? I think that's a great honor, Pratap, to get a accolade from Dr. Sriram Bhatt.
Thank you.
Anyone else to comment?
I think actually I am planning the next part, especially the approaches. Like you may be knowing the anterior approach, like hanging maneuver. So many maneuvers are described. I think the students may not know these things. So I thought of taking it as a separate lecture.
Yeah,
Pratap, one small doubt, please. This hello, Pratap.
Yeah.
Yeah, our postgraduates still maybe having doubt because they thought Glissonian capsule is outside. They never heard about Lineck capsule or confused about that. Whether they should liver is covered by Glissonian capsule or
no, liver is not covered by Glissonian capsule. Actually, Glissonian capsule is the extension of your hepatoduodenal ligament.
It is inside, and the liver is not covered by the Glisson. It is covered by the Lineck capsule. And many staff members also having confusion about that. So they should be clear about that. It is covered by the Lineck capsule, not by the Glissonian capsule, which is totally different, and it is in the deeper plane. That's what probably they should know, I think.
Yeah.
Thank you.
Thank you, sir. Any other questions from the audience, please? Now, the Kiran is commenting on a little bit on the exact location for incisions for Glissonian pedicle axis.
So actually, I
that will be covering the next session.
That. Yeah, I will discuss in detail the next page for that. Actually, I have made that into this lecture, but it will be a very lengthy lecture, and most of people want to listen to it. So I thought of cut shorting.
Okay, fine. So, Prathapan, thank you so much for a wonderful lecture. Then we'll just be waiting for the next one. Thank you so much. Thanks, everyone. And actually, thank you, Dr. Sriram Bhatt. And we have a very nice weekend, Prathapan. Thank you.
Thank you. Good night.